Good morning. It's a pleasure addressing such a beautiful, small yet beautiful crowd. So I'm Mazen. I'm from Cloud Stores. I've been working for the company for 11 years now. And just 3 years ago, I started promoting and talking about neuro and spine endoscopy, which has been a pleasure actually, because it was interesting to find out that Cloud Stores, when other companies gave up on neuro endoscopy because they thought this is a small field, it's not worth investing in. Cloud Stores being a reusable company concept, being a family-owned business, caring about medicine and about training and education. So for Mrs. Stores in particular, who's the owner of the company, neuroendoscopy has been a major interest. It's a field that we are investing in, and we're putting a lot of efforts towards research and development, trying to come up with product that surgeons like you can use for the benefits of societies and patients, etc., etc. So it's a pleasure to talk to you about our portfolio. I'm going to try to be brief. Please, if you have any question, let me know about them. Today, I'm going to present about upper brain, about cranial endoscopy, our portfolio in general. Tomorrow, I'm going to have, thanks to Dr. Qureshi, he included also a session about skull-based endoscopy. So I'm going to talk about how to build up a skull-based set, because skull-based instruments are so wide and variant, because there's the nasal phase that's different than the sinus phase, that is different than the cellular phase. So each of them has specific instruments that is common between ENT in some cases and then neurosurgery on the other. And then on day 3, I'm going to talk about spine as well. Kenya, for example, or African countries, with the verification, it's called the VTOM 3D. We're going to try to have it tomorrow so that you can also take a look at it to understand what it is. So it's used for all type of microsurgeries, like in neuro, like in spine, as well as other specialties. And this is not a standalone solution. It's part of the same tower, of the same trolley. And then from the same tower, we can also, starting with the 4K, which is an 8 million pixels, going to the normal HD, which is 2 million pixels. We have them in autoclavable and non-autoclavable. And then we have the ICG camera for the ICG scopes in order to detect blood protrusion into different tissues, as well as to identify normal and abnormal tissue, to differentiate between normal tissues. And tomorrow I'm going to share some studies, and I'm going to talk a little bit about some applications for the ICG in neurosurgery. So, and then also on the same system, we can connect the flexible scope. Also, we have a flexible scope available for you to try and to see for ventriculostomy. So it's all part, the message that I want to deliver, it's all part of one system. The whole system, it costs less than an operating microscope, a good operating microscope, I mean, an average to a high end, and yet it can be useful for practices in a lot of places. So, for you to know, an endoscopy tower consists of a monitor to see the image, a camera to transmit the image from the human body to the monitor, because you're working in closed cavity, you're not opening, and you're not using OR lights or outside or headlights. So you need a light source, which is a lamp that just transfers the light into the cavity inside. And then the cable transmits the light from the light source to the scope which is your eye inside. This is what's going to be inside visualizing. And then documentation can be anything from a USB on a camera to a printer to a DVD recorder, or it can be an advanced documentation system where you can also put your commands, voice and written commands. You can document video and images, as well as can be connected to the hospital information system and the PACS system of the hospital to extract images from the PACS, radiological images, or to send directly when taking a photo in the OR, directly stored on the hospital information system. So it can all be part of a small documentation unit, which we call AIDA in stores. And then the unit specific for neurosurgery, like electrosurgical unit for bleeding management and bipolar and monopolar coagulation, and then the motor system for perforating, for craniotome, for the different drill system available. Different approaches, upper brain, skull base. Today, the upper brain is the parts. Our motor system has all the accessories that is needed from the perforator to the craniotome to the different drills available in diamond, standard, coarse diamond, fluted, coral burrs, or are available for use. Moving into shunt placement, which is a standard procedure in neurosurgeries. A lot of patients can only be treated with a shunt, especially where other treatment like ETV, for example, did not work. For that, what we offer is a shuntoscope. It's a simple needle, 1 millimeter semi-flexible telescope that is connected to any endoscopic camera you already have. It's reusable, it's autoclavable, especially with the new version now, which I'm gonna come to. And the objective of it is to place the catheter of the shunt under endoscopic view, to place it inside of the ventricle. And it can be used for difficult anatomy in cases of trauma, cases of accidents where the anatomy has shifted or changed inside. It can be used in cases where the foramen or the ventricles are very small. So to access it with the shuntoscope under endoscopic vision, of course, for documentation and surely for training, because a lot of senior neurosurgeon, they can blindly place a shunt. But sometimes also it's good to have such a product to teach others, to show residents and fellows how to safely place a shunt, because failure of shunts, a big percentage is due to malplacement from the beginning. Now, the new version is autoclavable. Not only this, but also it has a working sheath with it, where a ventriculostomy forceps can be inserted for ETV, where biopsy forceps can be inserted, scissors and a grasper can be inserted, as well as a monopolar wire, which is the electrode, polar electrode. I met a surgeon in Russia. I don't know if you met him in Cairo, Dr. Qureshi. He's Albert Sovyanov from Tuimin. He uses this for a lot of cases. He uses it for aqueductoplasty, for ETVs, all of his ETVs, for biopsies, of course, as well as for shunt placement. And he promised us to send us some videos that we can share with surgeons, which I'm waiting for, which is actually interesting to know. So the new version is, of course, autoclavable, but the previous version was not. So this is regarding the shuntoscope. And then moving towards ETV, which has become, for a lot of surgeons, the first line of treatment in neurosurgery. So a product map or a portfolio map that we have, the GAP system, which is still available. Some surgeons, they like it because it can connect with it, the CUSA, which is an ultrasonic aspirator. It can connect to the GAP. The LUTA, or the little LUTA, which is the newest among the upper brain portfolio, which is our focus product because surgeons' acceptance is very high. They accept it. It's rigid. It's more rigid than the GAP and the OI, because the GAP and the OI, there's the sheath and there's the scopes that are different. So anytime the scope can be broken, and then the system is malfunctioning. While the LUTA and little LUTA all are embedded into one. So the sheath, the scope, irrigation, suction channel are all in one, and it's more rigid. And I'm gonna share some photos as well to see the image quality of the LUTA. The optics is really incredible. And then the OI, which a lot of surgeons, they like it. It's a handy pro. It's easy to use. It's like a gun that you hold it, and then you have a sheath, and then you have the scopes that you put inside the sheath. Also, we have them available. We have the LUTA available. We have the OI available, so that you can have a look at them. And then the instruments are just like the LUTA and the GAP instruments. So ventriculostomy, biopsy, grasping forceps, scissors are similar, but of course in different sizes. The flexible scope, the shuntoscope that we talked about, and then the GMB scalp dura retractor is for endoscopic assisted craniosynostosis surgery. Also, I'm going to talk about it in 2 slides. First of all, the LUTA. There's the big LUTA, there's the little LUTA. Some surgeons, they use the big LUTA for adults and the small LUTA, the little LUTA for pediatric. Other surgeons, they use the little LUTA for adults and pediatric for only ETV because it's a small size. It's similar to the size of the OI, which is a small size. So, and then if they want to do bigger surgery, like tumor, like cyst removal, they use the big LUTA because it has a larger working channel where they can aspirate and they can grasp more tissues from inside. So we have them in 6 degrees, not in 0, while in the OI we have a 0 and the GAP it's a 0, and the LUTA it's a 6. Why 6? Because as soon as the instrument tip comes out from the working channel, the surgeon wants to see it. Not to go a little bit far so that they see the tip with the 0 degree. So with the 6, you see it as soon as it comes up, the head comes up, you can see the instrument easily. And also the LUTA are available in 30 degree, especially to see the aqueduct as well. So available in both, but 6 degree is the mostly used telescope. And then the instruments, these are the general instruments that are common for all the system. The scissors, biopsy, I'm sure that you all know them very well. The ventriculostomy, which is very important to penetrate into the floor of the third ventricle in an ETV case, grasping forceps and biopsy forceps. And also for bleeding management, there's the bipolar forceps and there's the bipolar electrodes that surgeons, they find useful as well in ventriculostomy, the electrode, the bipolar electrodes. And then there's the suction and irrigation channels that we can see them in the lotoscope, which we said it's part of one, it's grouped in one. And then the central working channel, which is this channel right here. Okay. Now, what's the difference between, for example, if we take the gap, which is this one, the working distance of instruments is open, it's flat like this. While with the lotta and the little lotta, it's a dedicated working channel. So it means that the instruments cannot move. So it goes only in one direction. If you want to move, you just move a little bit the telescope so that you access a different area. And that's what the concept of the lotta was. So to have dedicated working instruments. It's worth mentioning something that all of these instruments, and which I mentioned before, is in the culture of Karl stores, is everything is reusable. We don't focus on disposable parts, and we're not interested in disposable and single-use parts. Because a lot of companies, they just come up with instruments that are single-use. And they get them into insurance and coverage and national social security so that they can make more turnover. For us, we focus on quality sales and not on quantity sales. It's not volume sales for us. For us, a small Lotta set means a big project for us. So this is how important it is neurosurgery for us. Now, for the Lotta as well as the other, introduction of the sheath, this is a step. It can be done in several ways. It can be done using a navigation system in developed ORs. It can be done using a pillowy sheath as a basic solution to have it inside and to measure the distance. Or instead of the normal obturator, we have an optical obturator where we can have a scope inside of it and a camera on it, and then we can introduce the telescope in the ventricle under endoscopic vision rather than doing it blindly. In some places, they're finding it cheaper and a valuable solution to use. And then once the sheath is in, obturator is out, and then telescope is in. So this is how, from the outside, from the technical part, this is how it's used. For the inside, of course, the professor, I mean, we're gonna have a lot of discussions and times with them to get to know that. Now, this is the ventriculostomy forceps on the left. We see it just above of the mammillary's body. And then the balloon catheter on the right that can be used to, as Professor Qureshi just mentioned, to expand the opening and to make sure that no recurrence will happen by closing of the floor. So, and this is, I want to show also the quality of the Lotta telescope. The optics of the Lotta are quite high. And this is another image as well that shows the quality of the image of the Lotta telescope. We have the Doctor to Doctor, which is a silver book written by Professor Schroeder. And we have a quantity around 10 here, hard copies, as well as we have soft copies that we can send you. So at the end, you will be having a copy and then a DVD as well of a step-by-step, not only ETV, but also patient positioning, instrument positioning, as well as more advanced cases like tumors, like colloid cysts performed. So this is also for you that you're gonna receive at the end. Bimanual instrument working. The Lotta system can be fixed. Some surgeons, they prefer to keep it mobile because they're afraid if they fix it and if the patient moves, then it's a catastrophe. They prefer not to fix it, to have it mobile so that if the patient moves, they move with the patient. Some surgeons, they like to have it fixed. They trust the anesthesiologist. They know that the patient will not move. And then while having it fixed, you can have a bimanual working, like a colloid cyst procedure in the right picture. You have a grasper, which is the flexible instruments on the left that is going from either the irrigation or the suction channel. And then from the central working channel, you have the 2 millimeter bipolar electrode so that when you're pulling, you are the bimanual technique that can be done with the Lotta. Dr. Qureshi, with the OI, bimanual can also be done? Bimanual working. With the OI, no. Just the central working, yeah. So these are the different dimensions. I mean, these are technical details I'm not going to spend time on. Just for you to know, if you can just look at the outer diameter and the inner diameter. So outer diameter for the Lotta is 6.8, little Lotta is 4.5. Inner diameter is 3.6 and then 2.4 or 2.3 for the little lotta, which is the central working channel. The same system can be used for a lot of ventriculostomy cases, of course, starting with, as Professor Qureshi was mentioning yesterday, with the basic procedure first, septostomy and ETV at first, but also it can be used later on to address bigger procedure. I received a paper lately about a hematoma in the brain, where a surgeon used the lotta and then used some sort of evacuations, like suction catheters, to remove the hematoma after a trauma case. I'll be glad to send it to you and to get your feedback also on such a procedure that can be done. And he used the lotta. He had the lotta and he used it for that particular case. Now the flexible, this is the new video flexible. It's an HD image. Here we have the old fibroscope that can be connected on any endoscopic camera. The image of the new one is much better than the old one. Yet the old one was a workhorse for neuroendoscopic surgeon. I mean, especially on the African continent, where they have the most experience with fibroscope in the world. And a lot of surgeons from Germany, from Europe, or from the US in general, they come to Africa to learn about flexible endoscope, because they don't have the experience that it's on the African continent. And so the new flexible, it's deviating up to 270 degrees, both direction, the deflection. It has a working channel of around 35 centimeter. The whole telescope is around 40 centimeter of length, and it needs the HD camera to connect to. So it cannot connect to any camera, while the fibroscope can connect to any camera, as we're gonna see this afternoon. Craniosynostosis, whether sagittal or coronal, a system was developed and to do endoscopic assisted. So instead of having a big opening, for example, for the sagittal craniosynostosis, to cut this bone that has fused, the suture that has fused, the idea here is to have one or two opening, and then under the skin, because the retractor will have one to protect the dura, one blade to protect the dura, and one blade to elevate the scalp. And then with the scissor, the surgeon can cut in between. And the good thing about endoscopy is that you can see the bleeding where it's happening, so you can coagulate on the spot. While if you have a complete open, you will have a lot of bleeding that it's not easy to know from exactly the bleeding where it's coming from. So instead of coagulating everywhere. So blood loss is less, surgical time is less, baby can be discharged second day or the third day, not like an open procedure where more time is needed. The surgeon who developed the system uses a kind of a helmet to remodel the skull after surgery, but a lot of other surgeons, they use the same instrument but without a helmet, so they just follow up with the baby. All of the instruments you see on the left, from the bipolars to the scope, these are all standard instruments from skull base available already in the OR. So what is needed is only the scissor and the retractor, and these are both, again, reusable. So they will be used for a long time. So another solution that I wanted to present. So with this, I come to my end. So the skull base, I'm gonna leave it till tomorrow. Maybe I'm still ahead of time. If you have any questions, I will be more than happy to answer them.